Hello, it's Peter and Kansa. Thank you very much for joining us in this seminar on analgesics in dentistry and their effective use. I appreciate the invitation from the Academy of General Dentistry. As we get started today, I want to let you know that most of my statements hopefully will be backed up by evidence or articles that are appear in the scientific literature. I will try as much as possible to go on evidence-based information, but that does leave us a little bit stuck sometimes. Perhaps some of you remember from last summer, there was an article talking about flossing and how really no didactic, randomized controlled, double-blinded studies had been done to show the effectiveness of flossing. Now, of course, the message that people took from that was that you didn't need to floss because it hadn't been proven to be good. That's an evidence-based conundrum. And really the problem there isn't that flossing wouldn't be good for you, it's that there's really not a reason to do a randomized, double-blinded, controlled study on it. Does that mean the knowledge is no good? Well, not really. And so as we go through and I try and quote different papers, different literature that are talking about some of the evidence that people have gathered through scientific experimentation, let's understand that evidence-based healthcare is really most applicable if the science behind it is infallible and comprehensive. And unfortunately, science is neither infallible nor comprehensive. So the individuals will react differently to all kinds of things. That certainly is going to be true with regards to pain and the use of analgesics in dentistry. There are many examples of many valuable things to healthcare that have been tried and implemented without the use of randomized, controlled, double-blinded studies. For instance, hip replacements, which you would never, of course, do a placebo experiment on, and cataract treatments, which, again, same obvious reasons you would never do placebo-type experimentation on. Let's start the basics of pharmacology then. We're going to talk about briefly pharmacokinetics and pharmacodynamics and the difference between the two. Pharmacokinetics is what the body does to drugs. It doesn't really matter what kind of different drug you might take. Any drug that enters your body will go through these four stages: absorption, distribution, metabolism, and elimination. Doesn't matter the drug, doesn't matter the type of drug, doesn't even matter the route of administration exactly. They're all going to have these four stages, and we'll talk about that as time goes on. Pharmacodynamics, on the other hand, is what the drugs do to the body. Simply put, this is why we take the medication. Are we taking the medication because we have an infection in our lungs, or are we taking the medication because we have pain in our ankle? This is pharmacodynamics, and it includes the duration and magnitude of the responses. For the most part, drugs are going to work in a drug response format. The more drug you take, the greater the response. When we shift our focus now to pain and the pain pathway, here's a good illustration that I pulled from a medical university actually in Pakistan. The idea here is that you have a site of injury, down in this case, by the patient's foot, and that message travels up via the spinal cord and the dorsal horn of the spinal cord specifically to the brain. In the brain, that message of trauma gets interpreted into some sort of response, emotional, potentially, physical, potentially, both, probably. And then we go into action, or we have a certain feeling about that. This is a little bit of an oversimplification of how pain works, but I thought it was a very clear illustration. And the nice part of this particular illustration is that we are showing the site of injury, we're showing that there is a pathway. What we're not showing is the modulation that happens along the pathway. The dorsal horn of the spinal cord, as I mentioned, is going to transmit some of these messages up, but in the brain, many things can happen. It matters if you dive for a loose ball in volleyball, or if you trip on your way to a movie. In one case, you expect some physical discomfort, in the other one, you don't. And although the trauma may be the same, the experience is quite different. Slide that I actually lifted from a medical university in Pakistan, but it I think clearly talks about the pain pathway. If you go back a few hundred years to René Descartes, the philosopher, the famous philosopher, he was the first to sort of talk about the mechanism of pain and how it worked. More or less, it was like pulling a string at one end, your finger, your arm, your toe, and it rings a bell in your brain and you sense pain. more or less that was the explanation of René Descartes. It's obviously a little bit oversimplified, but I think we didn't appreciate exactly how oversimplified it was until we sort of have come into the last 50 years or so of technology that are allowing us, technology and experiments, that are allowing us to really see how complex this is. So while there is a site of injury on this picture down at the toe, and we know that we are going to have that information travel up, it really isn't as simple as a single tube that gets to our brain. The other thing that we have to remember is that we're going to interpret pain. So pain has different context. If you are playing volleyball with a group of friends and the game is close and you make that dive to make that amazing stop to make sure you get that point, and you scrape your knee, you get up, it doesn't bother you, you keep playing because you almost probably didn't even feel it. On the other hand, if you're just heading out for a nice supper with your husband, your wife, your spouse, your girlfriend, a group of friends, and you trip on the sidewalk and you scrape your knee there, the pain is different. Not that the trauma was different, but the pain is different because the context was. Understanding that as dentists we're kind of feared because we tend to, or it appears that we want to hurt people sometimes, we have to acknowledge that some of the things we do hurt. In context, we have to be aware that that is going to affect the fact that people think that we're trying to hurt them sometimes, is going to affect their actual sensation or experience of pain. Let's talk about some analgesics. First, I think we have to talk a little bit about what the pathways would be. Now, this is a very dry slide, and I'm not really going to take time to waste your time in going through this. All this is really saying, this particular slide, is that we have the brain and we have peripheral, what are called nociceptors. These are the receptors that feel pain and transmit the pain message up to the brain. But you can see there's a lot of things that are affecting things along the way. So there are a number of arrows that come in from the right. There are a number of arrows that go up and they go down in the center column. This is really telling us that pain is a complex experience. This is a nice diagram that I also pulled off of Pinterest, actually, and it I think illustrates things a little bit more clearly. If I can zoom in a little bit on this slide, then we will see that we will have the site of pain. Of course, for dentistry, it's in the mouth, but nonetheless, we're doing some sort of trauma, some sort of damage to an area of the body. That message will get transmitted through the body and be carried up through the fibers to the brain. Now, these yellow figures that you see along the way are significant, and they're significant because they matter. If we, for instance, are able to block something that's happening down here where the triangle is, then we're working peripherally at the nociceptor. So this is an area, for instance, where opioids would work and cannabinoids would work and where NSAIDs would work. So this is sort of trying now to block the message initially at the level of the nociceptor. In dentistry, we largely use local anesthetics, and now I'm sort of circling this diamond figure. What we're doing now is stopping the pain transmission. Yes, it has started, but if we can block the area right here, then the message is not going to be carried out to the brain. This, again, is how local anesthetics would work. As we go further up our pathway, we come to this hexagon figure here. The hexagon figure is really representing the dorsal horn of the spinal cord. And so this is where pain transmission is transmitted. And we can block this area as well with things like opioids again, and with materials like NMDA receptor antagonists. For instance, nitrous oxide would work here, ketamine would work here. And it's working at the level of the spinal cord, again, to interrupt transmission from what would otherwise be experienced as a painful stimulus. As we go a little bit farther up the pathway, we have this circle over here. This is called the descending inhibitory pathway. And this essentially says, okay, is there a way that we can moderate or change what the spinal cord is observing? And there is, and opioids will work here, tricyclic antidepressants will work here, cannabinoids will work here. This is one of the reasons why medical marijuana is used for chronic pain, because it actually affects a number of pain pathways. Finally, let's come up here to the brain where we have this square, and this square is really representing central inhibition of pain interpretation. Tylenol, acetaminophen works here. Opioids work here, cannabinoids work here. So it is not, obviously not as simple as Rene Descartes suggested, maybe with pulling a string on one end and having the bell of pain ring in your brain. As far as categories are concerned with regards to analgesics, there are three general categories. The NSAIDs we'll talk about first, then there's acetaminophen, and there are opioids. Opioids, of course, are all over the news at the moment because, unfortunately, they're really not being used very well. The problem with that, I think, as we track the source of that problem down, is that much of the fault lies at our feet. That is, dentists who are prescribing these medications that, unfortunately, these people are using and abusing. Let's talk about general guidelines on how to handle pain. Well, first, if there's a source of pain that can be treated, we need to treat and eliminate the source of pain. Second, if a particular regimen doesn't seem to work, or historically the patient tells us that a particular regimen does or doesn't work, we ought to follow whatever it is they're saying. Patients know their bodies better than we do, and not all the medications are going to work exactly the same way at exactly the same dose. So we need to listen to our patients very closely, understand their needs, and understand their responses by checking in with them. One of the things you want to do if you do choose to prescribe an analgesic is maximize either the NSAID or the acetaminophen doses before you add opioids. Lots of different reasons for that, but essentially the idea here is that you don't, there's a saying that says no good deed goes unpunished. And so the idea now is that if you give any drug, and it doesn't matter which one it is, if you give any drug, there is a potential for an adverse effect. Sometimes it will be toxic, sometimes it will be allergic, sometimes it will just be one of the side effects that ponies along with whatever it is. For instance, if you have an opioid, any opioid, you're probably going to be constipated. That's just what happens along with opioids. You don't only get the pain-killing response, you get all the other stuff that comes with it. Maybe nausea, maybe drowsiness, almost certainly constipation. The fourth bullet here talks about patients not responding to one NSAID. Everybody has, we're creatures of habit. Everybody has a favorite NSAID or analgesic that they would go to. Mine happens to be ibuprofen. No particular reason for that. It just seems to work most of the time. If the dose that I gave doesn't work, I may probably try to increase the dose first. If an increased dose doesn't work, depending on exactly how bad the pain is, I either want to attack it from a different direction or I want to change NSAIDs. There's nothing that says that changing NSAIDs will not be more effective. I think as we look, if I cast my eye toward the future, and as genome testing, genetic testing becomes a little bit more frequent and more popular and more pervasive, I think what will end up happening is you will know which NSAID is best for you and you will know which dose is best for you. So soon, instead of sort of treating the average, we're going to treat individuals much better. In any case, if you are using NSAIDs, acetaminophen, or opioids, you want to avoid chronic use. Again, no good deed goes unpunished. You want to be very careful about making sure that you don't damage kidneys or livers or, in fact, induce an abuse situation. If we take a look at what's called the arachidonic acid cascade, this is sort of the grandfathered pathway of pain. And essentially what happens is from a basic arachidonic acid, once we act on AA with a number of different enzymes, we will create some things that will mediate pain. They'll mediate other things as well, depending on what the enzyme is that's interacting with the arachidonic acid. So the box that I have highlighted on this particular slide talks about COX-2, which is a cyclooxygenase enzyme, and it's one of the versions of cyclooxygenase. If this gets made or acts upon arachidonic acid, you're going to produce prostaglandins. If you produce certain prostaglandins, you're going to experience pain and inflammation. There is a COX-1 as well. There are lipooxygenase enzymes as well. All of these things can mediate different effects, all coming from arachidonic acid. Generally speaking, when we're talking about analgesia, we're looking probably to interfere with COX-2. Certainly that's what the NSAIDs do. I show this table just because I want to have a relative idea for what analgesics work and at what doses. The Oxford League table is known as sort of a pain table, And really what it's doing is it's ranking various combinations or dosages of different analgesics to tell you how effective it is. The column on the right, NNT, stands for number needed to treat. What this is saying is how many people would I have to give this dose to, or this combination of medications to, in order to achieve the result that I wanted. In this case, to achieve analgesia for whatever it is that's hurting. You can see at the top of the list is ibuprofen at 800 milligrams. The number of people that I would need to treat in order to get the effect that I wanted would be 1.6. You have to take it from me that anything sort of below 2.4, 2.5 is a pretty good number. If we go right to the bottom of this table, we'll find that codeine at 60 milligrams, I would need to treat 16.5 people before I got the result that I wanted. So clearly, codeine by itself is not a good analgesic. There are a number of reasons for this, primarily, and we'll talk about this more when we get to the opioids, but primarily because codeine is a prodrug. Your body needs to convert codeine into morphine in order to get any of that pain-relieving effect that you wanted. Some people are very good at changing codeine to morphine. Some people aren't very good. Because it's unreliable and because you can't really tell by looking, it makes codeine a very unreliable by itself and a very unreliable analgesic. As we go further into the table, the second thing is ketorolac, which is sold at least in Canada as Toradol. Diclofenac many people don't use, but it's actually quite good. Acetaminophen or Tylenol with codeine is good. Acetaminophen with oxycodone is good, unless, of course, we're getting into the whole opioid issue. Diclofenac, ibuprofen, acetaminophen, ketorolac in a smaller dose, and ibuprofen again. So ibuprofen at 200 milligrams, the second last thing there, is still at 2.7, an awful lot better than a maximum dose of codeine. So let's keep all these things in mind. And what I said, or at least the way I think of it, is if the number is less than about 2.5, then it's a pretty good analgesic combination that you're throwing at people. Let's talk about the NSAIDs first of all, because they used to be at least the most popular analgesic in dentistry. It's interesting that NSAIDs, in my opinion it's interesting, that NSAIDs are named for something that they're not. They're non-steroidal anti-inflammatory agents. That's kind of interesting because I can't really think of another drug category that's named for what it isn't. But if you follow the history of NSAIDs and their developments, then the reason for their naming becomes a little bit clearer. By mechanism of action, they are looking to inhibit COX-1 and COX-2 enzymes. COX-2 enzyme is the primary one that we are looking at because when tissue is damaged, as we would do in some forms of dentistry or dental therapies, then it's the COX-2 enzyme that gets activated. If we can manage to deactivate the COX-2, then we're going to decrease the number of pain mediators that are being circulated. NSAIDs have a number of therapeutic effects. 1, they're analgesic. 2, they're anti-inflammatory. 3, they're antipyretic, so they take care of fever. And 4, they're antidysmenorrheal. The first 2 are really the key. Obviously, we're looking for the analgesia. But if you think about what causes pain in dentistry, very often it's caused by the fact that we're doing something that has caused inflammation. If that's true, then one of the things we really want to have is an anti-inflammatory on board. So when we can do that, it's, I think, of great advantage. That's why my go-to analgesic is going to be, still is, NSAIDs. The downside of acetaminophen is that it really doesn't have much in the way of an anti-inflammatory effect. If we take a look at various dosages for NSAIDs for post-operative pain, and once you've done something that you think or is likely to hurt afterwards, then we see that we have a number of different, this chart goes through a number of different things. ASA, or acetylsalicylic acid, is the granddaddy of NSAIDs. I don't think it would exist on the market today if we were counting on it being the only pain reliever, because as a pain reliever, it's actually not very good and it has a lot of other downsides. But it exists in the marketplace probably more because of its platelet inhibition than anything else. Nonetheless, because it was the first, it's what we're going to compare things to. Ibuprofen at 400 milligrams is a good adult dose. The frequency 4 to 6 hours, PRN, or as needed. The daily maximum has an asterisk next to it because that daily maximum is under debate. Under debate for 2 reasons. 1, all NSAIDs are a little bit renotoxic, so they're going to hurt your kidneys, especially if you're taking them for a long period of time. Also, if you're worried about dealing or counteracting the effects of aspirin, which you would be taking for its quote-unquote blood thinning effects, then you may want to decrease the amount of ibuprofen that you have on board. To this, at least in Canada, to this point, they have not decreased the daily maximum dose, but I know that Health Canada, at least here, is looking at it, and I'm sure the FDA is probably looking at it in the States as well. Diflunisal, naproxen, ketorolac, diclofenac, celecoxib. Of these, only the last one, which is Celebrex, is a COX-2 specific inhibitor. All the others are going to inhibit both COX-1 and COX-2. Again, if no good deed goes unpunished, we realize that all the effects that we're going to get are all the effects that we're going to get. Let's start with the acetylsalicylic acid, ASA or aspirin. It has a very, very long history. I won't bore you with that. But eventually it was developed by Bayer, which was a German company, as aspirin. Its main draw at the time was that it was less irritating than salicylate-based medicines. And now, as I say, it's not a particularly good analgesic, but because of its antiplatelet effect, which is irreversible, and that's unique among the NSAIDs, people are continuing to use it as quote-unquote a blood thinner in order to hopefully prevent strokes or heart attacks. Ibuprofen, I would argue, is the most popular of the NSAIDs now, for at least in dentistry. Patented by the Boots Group in 1961, that's back in the UK. It was first sold there in 1969, and it's an effective and very popular NSAID. I think that certainly in Canada, the brand names are Advil, Motrin, and Nuprin. If you mention Advil or Motrin to most anybody, they recognize what it is you're talking about. I think Advil has won that war by the way of ibuprofen because they put a candy coating on the outside of the pill, making it a lot more fun to take. The effective dosages are 200 to 400 milligrams every 4 to 6 hours. You certainly can go up to dosages of 600 milligrams. You certainly can go up to dosages of 800 milligrams, but as you start to increase these doses, you're asking for bad things to start to happen. The bad things that you're talking about with ibuprofen really are probably going to be a little bit of gastric irritation, but more specifically, you're going to plateau out with regards to its ability to relieve pain. When that happens, all that you are actually doing at that point, if you're increasing dosages, are increasing the frequency of the adverse effects. Loading doses I find very effective, and so depending on what the issue was, I will ask people to, depending on, again, the dosage that I prescribed, I may ask them to take a bigger dose first. So for instance, if it's wisdom teeth that have come out, implant surgery, periodontal surgery, endodontics, then I may say, yes, I would like you for at least for today and tomorrow to take 400 milligrams every 4 hours. But the first time you take it, please take 600 milligrams. That loading dose is I think, one of the important strategies with regards to staying ahead of the pain. Another important strategy, which is not unique to ibuprofen, is if you think analgesics are going to be required, see if you can get the analgesics on board before the local anesthetic wears off. Ibuprofen, because it's been very popular, has come in a lot of different forms. There's, as I mentioned, the candy coating on some of the pills, the Advil pills. There are now liquid gels. There's an ibuprofen lysine, faster onset, better peak analgesia. It's popular, and so people are looking for ways to improve that. Very good drug. I really don't have any particular downside about it. Health Canada released a report in April of 2015 that talked about prescription strength ibuprofen. So now you're talking about dosages of 400 milligrams, 600 milligrams being linked to an increased risk of heart attacks and stroke. So part of the issue now is that what other mechanisms are we beginning to affect if we're increasing the dose? Again, this probably is not an issue when you're talking about taking 200 to 400 milligrams at a time. It happens when you're taking 600, 800 milligrams and getting up to that maximum dose, as I mentioned before, 3,200 milligrams a day, but the risks are cited at about 2,400 milligrams a day. So while it's a very good analgesic, we have to be very careful with where the risks lie. Naproxen is another NSAID that gets sold, or at least was first sold as naproxen. It's probably more popular now as Aleve. It's indicated for mild to moderate pain or for osteoarthritis or other types of arthritis. Again, remembering that anything with itis really is inflammatory. So if we put an NSAID against it, a non-steroidal anti-inflammatory drug, then we're going to have probably very good success. One of the reasons that it's very successful is because it has a very long elimination half-life. So it's slow to onset with its peak levels hitting in about 2 to 4 hours. But if you're talking about a chronic sort of pain anyway, like arthritis would have, then whether it's 1 hour or whether it's 2 hours or 3 probably doesn't really matter. The fact that it lasts for a long time and now you maybe only need to take 2 pills a day is very helpful. So it's a long elimination half-life is good. One of the downsides with regards to dentistry is that it has more gastrointestinal irritation than ibuprofen does. This again, naproxen, is a very good drug to use a loading dose with, partly because of its slow onset, partly because you want to keep your blood levels above a therapeutic height. Ketorolac in Canada at least is sold as Toradol, and it was marketed as the first injectable NSAID. If you take a look at the dosages for Ketorolac, you'll notice that the injected dose is actually higher than the oral dose. It's the only medication that I can think of where that's true. The reason I think that's true is because when you take a larger dose of Ketorolac orally, it's very irritating to your stomach. Because you get GI bleeds, because you get the GI irritation, you really have to keep the dose down. 10 milligrams, which is the size of the tablets, is not subtherapeutic, but it's one of the things that we want to pay attention to because it's not going to be as effective, per se, as injecting it. So the best strategy with regards to the use of Ketorolac is if you can manage to give an intramuscular injection first and then follow that up with oral medications, that seems to give the best pain relief available. Understand that if you're giving an intramuscular dosage, which you're certainly welcome to go ahead and do, then make sure you're doing it correctly. One of the issues that we're having in North America now is sort of the obesity I'll call it an epidemic. The problem with the obesity epidemic, or with trying to inject someone intramuscularly who is obese, is that you may simply land subcutaneously. If you do that, you land in fat, you land underneath the skin by using a needle that's a little bit too short, or by bunching up all the tissue under your hands while you give the intramuscular injection, then you really haven't given it intramuscularly at all. Your uptake is going to be very different. Again, remembering the pharmacokinetics, absorption, distribution, metabolism, and elimination, we're not going to get absorption and distribution in the same effective way that we should by injecting into a well-perfused muscle. So be aware that if you're going to give an intramuscular injection, that the needle length that you should be using is probably 1.25 inches to 1.5 inches. Diclofenac is sold as Voltaren, at least in Canada, it's sold mostly as Voltaren. While it has the ability to be taken as tablets called Arthrotec, usually, at least here in Canada, it's sold as a cream. So it's one of the few NSAIDs that is marketed largely as a cream, as a tablet, as a gel. You can use it as a suppository. If you choose to use Arthrotec tablets, understand that it also contains a prostaglandin called misoprostol. The problem with misoprostol is that it's abortifacient. That means it causes abortions. They're not spontaneous abortions, it causes abortions. So obviously if you are prescribing diclofenac, or more specifically Arthrotec tablets, to someone who's of childbearing age or trying to get pregnant, this is not such a great thing. In North America, not very popular, but in other parts of the world, Europe and other parts of the world, it's actually quite popular. Diclofenac the dosages for diclofenac have been suggested to be decreased to a daily maximum dose of 100 milligrams per day. That's down from 150 milligrams per day. And again, we're back into the same ibuprofen set of problems through a report written up in the Lancet in 2013 regarding an increased risk of heart and stroke-related adverse events similar to those seen with the COX-2 inhibitors, Vioxx and Celebrex. This particular warning applied to tablets into the suppository formulations. Some researchers have called for its removal from the Canadian market. That hasn't happened to this point in time. Diflunisal is sold under the brand name of Dolabid, developed in 1971. It's also a salicylate derivative. The issue with salicylates often is that you have a lot of gastrointestinal irritation. So if people have sensitive stomachs or they're concerned about that, then diflunisal is probably not that much better than using ASA. Having said that, it has a long half-life just like Aleve does, or naproxen. Its elimination half-life is 8 to 12 hours, but you again need a loading dose. Slow drugs, drugs that are slow to leave tend to be slow to build up as well, and so we want to be aware that in order to deal with the acute pain that would be caused through dentistry, we want to give that loading dose to hopefully get that response on board as quickly as possible. So your loading dose is going to be 1,000 milligrams first, and then you're going to use 500 milligrams twice a day. Chronic care is not really what we want. You are probably looking at a maximum recommendation of 5 days, maybe 6 days, maybe up to 7, but even that is kind of pushing it a bit with any NSAID, not just diflunisal. It does show diflunisal head-to-head with acetaminophen does show better analgesia, and that should be taken into account because not even that big a surprise. But we want to be effective in whatever dosages we're asking to do. In fact, its pain relief analgesia seems to be comparable to combinations of analgesia and opioids. As we move on to the COX-2 specific inhibitors, the two that, at least by brand name, would be recognized would be Vioxx and Celebrex. Now, the benefits initially were that it was going to have less GI bleeding, it was going to have it was going to induce fewer gastroduodenal ulcers, although there's a little bit of bacterial element there as well. The question then became, is there a predisposition to myocardial infarction? This initially was marketed as an arthritis anti-inflammatory drug. Terrific, except what happens now is that you interfere with any other antiplatelet drug that you might be taking, for instance, the ASA. If that happens because of the reversible platelet effect that you have, you really aren't decreasing the clotting that might happen otherwise. And so you may have an increase or a predisposition to myocardial infarctions and strokes. Vioxx was voluntarily taken off the market over a decade ago. I'm actually surprised it's been gone that long. I thought they would find a way to reintroduce it because it's very expensive to produce a drug. Celebrex has not been taken off of the market. Celecoxib has not been taken off the market, but its prescribed use has changed quite a bit. Speaking of Celebrex, here it is, and it's indicated for osteoarthritis and rheumatoid arthritis. The question marks at the bottom are different things that I've read in some of the associated literature. I'm not going to call that evidence-based exactly. I'm not actually even I shouldn't say I'm not sure why that is. I do know why people have tried to go after familial odontous polyposis, which actually is a predisposition to having polyps in your colon and in your rectum. And I understand what people were after with regards to mental illness because there are certain neurotransmitters that they thought could be affected by celecoxib. But these are way off-label uses and they're really outside the scope of dentistry. I'm just sort of showing them to let you know that sometimes experimentation goes on with lots of different drugs. With regards to its ability to deal with dental pain, celecoxib is not terrific. Its dosage is going to be 200 milligrams twice a day. Its elimination time is very good in that it's 10 to 12 hours, so you're not going to have to dose very often. And this is good because it increases compliance among our patients. Certainly the reason that most drugs or most prescriptions fail is because patients simply don't listen to what we ask them to do with it. If that's the case, if we can lower the number of times per day that people have to remember to take the medications, then it's more likely to meet with success. It's been found to be equal in efficacy to about 650 milligrams of aspirin with regards to dental pain. 650 milligrams of aspirin for dental pain is not a particularly impressive result. So in the end, it was not the panacea that we were hoping for. We were hoping that with the COX-2 specificity that it would simply deal with pain and we wouldn't have all the other issues with GI bleeds and all that sort of thing. In the end, there's no specific advantage to using celecoxib for dentistry. As I mentioned, no good deed goes unpunished, and so if we're going to choose to use the NSAIDs, we have to acknowledge that there can be some adverse effects that are associated with them. You can get increased bleeding. All the NSAIDs can do this, but clearly aspirin is the champion with regards to causing bleeds. In fact, if you were to invent aspirin tomorrow and try to bring it to market, it wouldn't actually make it. It wouldn't pass the safety regulations because it induces a little bit too much bleeding. It also damages the gastric mucosa. There is an estimate that talks about, in this particular case, the slide is talking about 16,000 deaths annually from GI complications associated with NSAID therapy. That's not just aspirin, that's all NSAIDs. And so there is a GI irritation concern that we have because of mucosa being damaged. Dyspepsia is really an upset stomach, and that's again because of the irritation that NSAIDs cause. Renotoxicity is going to affect the kidneys, and so if your patient has had a kidney transplant or has very bad kidneys, is on dialysis or anything else, you probably want to avoid NSAIDs. There are also examples of anaphylactoid reactions. I suppose anaphylaxis is also possible, but generally speaking, doesn't happen. Other NSAID contraindications are going to be active peptic ulcers. Again, I sort of keep harping on the idea that it's quite irritating to the gastrointestinal tract. Well, it is. And if that's the case, then stay away from it if people already have ulcers. If there are bleeding dyscrasias or other bleeding concerns, again, NSAIDs are not the way to go because you're going to get, at the very least, a reversible antiplatelet effect. If you have significant kidney disease, you're not going to use this. If it's been shown that you are hypersensitive or allergic by immunoglobulins in your body to ASA or any other NSAID, obviously you're going to avoid it. And specifically, this last one is particularly dangerous. The combination of severe asthma, which you probably ought not to treat on an outpatient basis, nasal polyps, and multiple allergies, also called atopy, can lead to something called acute respiratory distress syndrome. If you actually get an attack of ARDS, the mortality rate is about 80%. You can trigger it by using NSAIDs. And so if you have, again, this combination of severe asthma, nasal polyps, and multiple allergies, absolutely steer clear of the NSAIDs. Other NSAID contraindications are pregnancy. With regards to pregnancy, especially in the third trimester, there are some valves and holes that are in the fetus's heart that should be open and should stay that way for a while. It is possible to prematurely close some of these holes and valves that are useful in utero but not useful coming out too early. If you do that, you can damage the baby. Again, this is the sort of thing that you can't really test because it's clearly unethical, but the idea is there because they know that some NSAIDs can have this effect on newborns who do have these holes in the heart that persist. With regards to children and ASA as a contraindication, there's something called Reye's syndrome. Reye's syndrome is similar, I guess, the best analogy that I can draw is a meningitis. And if you happen to give children who are prone to Reye's disease, ASA and ASA only, then they will get Reye's disease. And if that comes in its fulminant form, again, the child is likely to die. So this does not apply to ibuprofen or ketorolac or any other NSAID. It's an ASA-specific contraindication. And the elderly, because of all the bleeding that happens with NSAIDs, we want to watch out. They tend not to be so well controlled with regards to their coagulation status anyway, or their antithrombotic status, so we want to be very careful with them. Finally, we want to be careful with various combinations. If people have poorly controlled hypertension, if they have a history of myocardial infarction, if they are on beta blockers, and all the rest of that list, then NSAIDs tend to interact with all these things, which will decrease the effectiveness of the drug, the other drug that they're taking. Doesn't it decrease the effectiveness of the NSAID? It decreases the anti-rejection drug. It decreases the sulfonylureal. And of course, because you already have inflammatory bowel disease, you don't want to throw something in there that's going to inflame your bowel. Let's move on now to acetaminophen. Acetaminophen goes by the generic name of APAP. Paracetamol is what it would be called if you went to the UK. It's actually a very, very old drug. First used in the 1800s, and then it was discarded because of phenacetin. Phenacetin, as it works out, was no better, and the search went on for other things, ibuprofen being probably the most significant of the bunch, but aspirin being the first of the bunch in 1899. Acetaminophen or paracetamol, if you're again in the UK, was introduced in the UK in 1955, and it sort of took off. Especially in the 1970s, Tylenol became the best-selling health and beauty aid product, which passed Crest toothpaste. Who knew that Crest toothpaste was all that popular? As an analgesic, acetaminophen is the popular choice in dentistry. I'm not certain that it's the wisest choice because it does not have any anti-inflammatory action, but it certainly is popular because people aren't going to worry about its interaction with a bunch of other things, specifically aspirin or the irritation that you get with the GI. There's no respiratory depression, so that takes you away from the opioids, which is also good. Very safe at normal doses. Category B is an FDA categorization that says they cannot show that it has any teratogenic or fetogenic, damaging effects to fetuses in humans. Now, they can't show it because they don't test that, but they do test it in animals, and it shows no toxicity to pregnant animals anywhere. So that gets you a category B. Category A would be the best, but you'll never see it because they would actually have to experiment on humans in order to get it. At very high doses, it's hepatotoxic. One of the ways this was shown early is that people, usually young teenage girls, would try to grab the attention of their parents in the 60s. And one of the ways they would do it before the 60s was to down a bottle of aspirin and then swoon onto the couch and say, oh, woe is me. And they'd get their horse or their car or whatever out of it. But when Tylenol came on board, people tried the same trick. The problem was that because of its hepatotoxicity in large doses, they would actually successfully kill themselves. But they would die 3 days later from liver failure, which is not a very good way to go. So be very careful about the high doses. And even now, there are concerns with regards to the maximum dose of 400 milligrams per day. We'll talk about that in just a moment. The mechanism of action of acetaminophen is actually not clearly understood. The original assumption was that there must be a COX-3 enzyme. Remember earlier we talked about with the arachidonic acid, COX-1 enzyme, COX-2 enzyme. They just figured that they knew that acetaminophen didn't block COX-2, but it must work peripherally. There must be a COX-3, we just haven't found it. As it works out, there's not a COX-3. And as it works out, it appears that acetaminophen really doesn't work peripherally all that much. It seems to be a central drug. And so if that's the case, it's actually more related to marijuana, THC in marijuana, than it is to the NSAIDs that we tend to use it like. It's also the leading cause of acute hepatic failure in North America. This is largely because acetaminophen is included in a lot of different medications. The thing that we're trying to avoid is a metabolite called NAPQI. Please don't ask me to break that down because I always forget what it stands for. But this is a metabolite of acetaminophen that is toxic if it doesn't get adequately conjugated. The problem is when you take too much of the acetaminophen, you get too much of the NAPQI to be conjugated fast enough, and that's where the hepatotoxicity comes from. It's not actually the acetaminophen, it's its active metabolite. The adult dose is 500 to 1,000 milligrams every 4 to 6 hours to a maximum of 4 grams a day. Again, they're looking at decreasing the maximum dosage to something like 3,200 milligrams per day instead of 4,000. Below that, I have what the pediatric dose is. It's best for kids to dose by weight, and you get to a maximum fairly quickly. I also have the toxicity there because, again, of course, we don't want to damage our children's livers. They say that acetaminophen is responsible for about 4,500 hospitalizations from overdoses every year. 16% of those overdose cases are going to be accidental. And the reason for that, again, is because acetaminophen is included as an additive in many different compounds. So we need to be careful about what the list of ingredients shows us for that cold remedy, for that cough remedy, for all the other things, especially when we're prescribing the use of Tylenol or ibuprofen. The dosages, as we well know, are available in sort of 325 and 650 and 1,000 milligrams, 500 milligrams. So there's extra strength Tylenol, there's regular Tylenol. I'm just using Tylenol as an example that we're well familiar with. It's a very good pain reliever. I'm not even sure that we know how it works yet, but we know that it works. And recently they came out with an IV formulation. Again, unless you're running IV medications, it's not a big deal. I haven't used it, so I can't really tell you firsthand what it's like. But because you're not taking it by mouth, because it doesn't go to the stomach, because it doesn't have that first pass effect going through the liver, it may be less hepatotoxic than the pill forms. Can you use NSAIDs and acetaminophen together? I think you can, and I think oftentimes you should. In fact, after one of my first analgesic regimen fails, the next thing that I am likely to recommend to my patients is that you go back and forth between NSAIDs and acetaminophen. Take one or the other every 2 to 3 hours apart and ping pong back and forth between the two. You're going to be attacking pain from different mechanisms, and when you do that, you're likely to have better coverage. This is not a long-term plan, this is a short-term plan. But in the short term, it can be synergistic, and that can be very, very nice with regards to the patient's effect. Let's branch out into opioids now because I think we need to. First of all, just by terminology, there are opioids, there are opiates, and there are narcotics. For the sake of argument, I'm going to stick with opioids because those are all the drugs with opium-like activity, and I don't really want to get into the legal definition of who belongs where. The mechanisms of action are actually multiple sites. There is some peripheral action, there is some central action, there is some pathway action. So what we want to do is find what opioids will do is find specific sites to them on the descending path inhibitory system, peripherally and centrally. What they will do is they will decrease your perception of pain. There's a very interesting paper, I thought it was a very interesting paper put out in 2007 regarding endodontics. And what they did is they injected mepivacaine and fentanyl close to the tooth that was having endodontic therapy, and they found that fentanyl actually was more satisfactory in pain relief than mepivacaine, which was a bit of a surprising result. But it did show us now that opioids really were not confined to working centrally. They did have peripheral analgesic actions. The opioid use and abuse is all over the media. It's very easy to find what the statistics are. I won't belabor them. I'll simply say again, as I said at the beginning of the broadcast, that we are partly to blame for this. And the reason that we're partly to blame for this is because many of the use, abuse, poor use of opioids started with prescriptions. There is a statistic, at least in Ontario where I am, there's a statistic that suggests that 70 to 80% of the addicts in Ontario got started with a prescription of opioids. That's a very high percentage, and because dentists are fairly often giving the prescriptions for opioids, we're at least partly to blame. That has led to various and different articles that have been written. This particular article I took from what's called the Hospital News. This was printed in December of 2015 here in Toronto at Sunnybrook Health Science Center. Here's an article that I pulled off from the FDA from March 2016, again warning us about prescription opioids. The opioid challenge is upon us. We really weren't actually even able to prescribe opioids until opioids or pain was described as the fifth vital sign. This happened in the 1980s, and when it was thought that we were simply handling pain badly, folks who were working outside of hospitals said, well, we should be able to handle pain well outside of hospital as well, give us the opportunity to prescribe opioids. The governments agreed, and they lifted the ban on outpatient prescriptions of opioids, and the problem was started. I have no idea how we're going to end this problem, but it's a big problem and we have to be aware of it. I'm not suggesting that opioids are bad with regards to analgesia. I'm suggesting that we have to be aware of what the downside is. Addiction is a real possibility, and opioids are almost as bad as, well, they're worse actually than sugar to the general public at the moment. So if you're going to use it, and I don't categorically rule them out in my practice. I do use them. I do prescribe them. I don't use them. I prescribe them. Be careful with the instructions that you give to your patients at the time of prescription. Understand, your patient should understand that there are going to be other opioid effects that are going to happen. No one cares if you're not going to cough, the antitussive effect, but people are going to care about the constipation. People are going to care about the sedation. People are going to care about mood alteration. If you're talking about giving an opioid to a child, you absolutely should care about respiratory depression, and people are going to care about nausea and vomiting. So these are things that can happen. Again, I'm not saying don't use opioids. I'm suggesting that when you do so, do it very carefully and with good forethought. With regards to opioids, there are two broad categories of patients. There are opioid naive patients who have not had any opioids for the previous week, and there are opioid tolerant patients who have had it, and then you get into a bit of a dosage problem when people have recently had opioids because they're going to be essentially desensitized or tolerant of whatever drug you intend to give them. This is a table showing equipotent opioid doses. Morphine is really the go-to with regards to opioids. It is the opioid that gives us the purest effect for opiates or opioids. Not very particularly good orally, pretty good when you inject it. Codeine, you can see, is considerably less potent than morphine. Oxycodone is on path with it, and meperidine, which is Demerol, is also very bad orally. Not bad injected, but not very good orally. The recommended doses if you're going to take opioids orally are codeine 60 maximum 60 milligrams, oxycodone 5 to 10 milligrams, meperidine 100 milligrams. So the top and the bottom ones there, codeine and meperidine, are actually not very good oral drugs at all, which is how we get into the oxycodone and the OxyContins and the Percocets. There are opioid combinations, as I'm sure you're aware, Tylenol 1, 2, 3, and 4. I actually didn't really realize that there was a Tylenol 4, and I'm not sure when I would use it. The problem with these combinations really is that the combination's in the wrong form. That is the wrong proportion, wrong ratio. Really what you would like to do, as I mentioned in an earlier slide, is you would like to maximize your acetaminophen or your NSAID dose before you throw on the codeine. If we are taking a look at 1,000 milligrams, for instance, as a maximal dose of acetaminophen, it's very hard to find a way to get a maximal dose of acetaminophen and a maximal dose of codeine at the same time using these single pills. The best we can do is to take 3 Tylenol 2s, which is going to give us 900 milligrams of acetaminophen, but only 45 milligrams of codeine. Again, codeine not being a great opioid in the first place because it's a prodrug, but it's the best we can do if we're looking to maximize what we're doing. Other opioid combinations that we should be aware of course, the that's what some of my patients come in saying. They're not patients for very long. When they say nothing else works, there's this special pill that I have to use. I don't remember the name of it. It starts with a oh, you mean Percocet? Yeah, that's it. And as soon as that behavior starts, you're pretty sure that they're trying to take you for a ride and that they're drug seeking. So again, by principle, I don't have a problem in prescribing opioids, but I'm very careful with who I give it to and what the dosages are. If they need to have an opioid combination, especially one that has something like oxycodone in it, then they're really only going to get a few days worth. I appreciate that there's no anti-inflammatory action in the acetaminophen, but I'm still going to limit the amount of days that they're going to have the opioid because I have other concerns. And frankly, if I handle it with a combination of NSAIDs and with opioids and with acetaminophen, we should be able to get over the hump in about 3 days. Here are some other opioid combinations. Again, I was pretty impressed that OxyContin and OxyNeo go up to 80 milligrams of oxycodone. I'm not really sure why that is. It really doesn't apply to the world of dentistry. I think we're talking about cancer type pains now. Clearly, you would have all kinds of adverse effects happening from dosages anywhere like 80 milligrams of oxycodone included. In 2013, Health Canada, on the recommendation of the World Health Organization, decided that you should not give codeine to children younger than 12 years of age. Again, the reason for this, we talked about a little bit earlier, but the reason for this is because codeine is a prodrug. It has to be metabolized into its active form, which is morphine. Some kids are really good at it. If you're really good at converting codeine to morphine, what you'll end up doing is giving an overdose of morphine inadvertently. When that happens, you're going to get all those bad things happening. The dangerous bad thing that happens with morphine is respiratory depression. So what would happen is these people, these kids, unfortunately, would essentially stop breathing. They'd forget to breathe. That morphine overdose would kill them. There's an analgesic ladder for pediatric pain. It's not specific to dentistry, but I believe the table applies pretty much to everybody. If you have mild pain, look towards either acetaminophen or NSAID. If that pain gets a little bit worse, then add on whichever, the acetaminophen or the NSAID that you weren't using. If that gets a little bit worse, then think about adding morphine. You can add morphine directly, by the way. There are morphine sulfate tablets that you could use. This is what I have on the bottom here of this particular table. Here's your dosage, and the middle or the third column talks about the maximum using 5 milligrams as a guideline. There is no fixed maximum dosage for it, and you can get tablets that have 5 milligrams per you can get oral suspensions that have 5 milligrams per milliliter, and it comes in 10 milligram tablets. If you were to give morphine for immediate release, you're probably looking at giving the 10 milligram tablet along the way. I will admit, I have not had much luck in prescribing morphine to my patients, because patients tend to look at you very sideways when you tell them that you're going to prescribe them morphine if they wanted something stronger. Sooner or later, I'll figure out what the right thing is to get them to accept, but they really haven't done so yet. Having said that, if you're going to give morphine directly as a tablet, given that it comes, at least in Canada, as 15 milligram, 30 milligram, and 60 milligram tablets, I'm going to look to give probably 15 milligrams first, and if I need to increase the dosage, then I'll be happy to do so by 50%. In Ontario, as of November 15th, there's this new set of guidelines put out by our regulators, the Royal College of Dental Surgeons of Ontario, that now have guidelines on the role of opioids in the management of acute and chronic pain. Now, these are two very different beasts. Acute pain is really caused by tissue damage that you can track down and is likely to heal. Chronic pain is a very different beast, both neurobiologically and even physically. In terms of how you handle it, it's well beyond the scope of what we're going to talk about in this particular seminar, but it's a wide-ranging and very different problem. Again, for the purpose of this evening, we're really going to limit ourselves to trying to handle acute pain. So let's talk about some analgesic strategies that we might be able to employ. So we acknowledge now that we have different sites of action. There are centrally acting drugs, opioids primarily, acetaminophen primarily, although both of these have peripheral effects as well. There are peripherally acting drugs, mostly NSAIDs. Is there a central component to that as well? There is, but it's less so with NSAIDs. The upside, again, to NSAIDs is that they have an anti-inflammatory action that we're very interested, perhaps, in using or exploiting. Our strategies would be to maximize NSAIDs first and/or the Tylenol/acetaminophen before adding an opioid. Before I even add the opioid, however, I probably would combine the NSAIDs and acetaminophen. Now, I have heard of other speakers that are suggesting that you should take the NSAIDs and the acetaminophen at the same time. Here's my issue with that. My issue with that is if someone is in pain, the last thing they want to do is wait out that last 1 or 2 hours where the pain is starting to come back without being able to do anything. If you trade off between NSAIDs and acetaminophen, then you get to take something every 3 hours. If that's the case, then just as that pain starts to kick in, it's almost time for your next dosage anyway. And in fact, with any luck, you're able, with an adequate dose, you're able actually to stave off anything happening in those 3 hours. And people stay very, very happy that they're not hurting. Pain is a great motivator with regards to compliance. So asking people to wait and wait and wait can sometimes be a bad strategy. In my opinion, at least for my patients, when I talk about them using combinations of NSAIDs and acetaminophen, I'm asking them to ping pong back and forth. Take one of them now, take the other one 3 hours later, go back to the first one 3 hours after that. Go back and forth. I would say you can do that safely for about 3 or 4 days. Again, if your patient does not respond to one particular NSAID, then switch to another one. Naproxen, naproxen is a pretty good option. Toradol, if you give the injection first, is a pretty good option. It's actually very good, but you don't have to. You should give the injection first. Consider your preoperative dosing. Preoperative dosing is going to be very helpful. That is, if you know you're going to do something that's going to induce inflammation or postoperative pain, why not try to prevent it? You can be, as another trivia question, you can try to answer who said an ounce of prevention is worth a pound of cure. If that's true, then preoperative dosing is very important. So even I underutilize it. But if we're going to do root canal treatments, if we're going to do implant surgery, if we're going to take out teeth, if we're going to do periodontal surgery, then very often I will ask my patients, adult patients, to take 400 milligrams of ibuprofen before we get started. I'm not really worried about the bleeding. The sort of reversible antiplatelet effect that you're going to get from a single dose of 400 milligrams of ibuprofen is probably not going to mess up my surgery. And if it does, I always have local anesthetic with epinephrine around that I can inject locally, and there are other local measures that you can deal with at least locally to the site of where your operation is. So I'm really not worried about inducing bleeding by giving a preoperative dose. I also like to strategize with regards to loading doses. Again, if I forgot to recommend the preoperative dose, then at least to try to stay ahead of the pain before the local anesthetic wears off, go ahead and take a double dose or a plus 50% dose of, again, for sake of argument, ibuprofen. There are some NSAIDs that we talked about that should have loading doses anyway. Make sure they do have the loading doses, because that way you want to get your blood levels up high enough to therapeutic levels where you're going to actually enjoy some of the relief from the pain that you would otherwise have. I also, as a strategy, say take your analgesic on a hard schedule for the first day. The idea is it's much easier to stay ahead of pain than to try to catch up to it. If you take the pill even though you don't need it and you stay ahead of discomfort, then by the next day, hopefully you'll be able to get off the pain medication, or overall you'll have a better experience. Again, I'm going to attack, if I need to attack pain because a single drug isn't working, I'm going to look towards various mechanisms of action. Did I switch NSAIDs? Yes. If I already switched NSAIDs, I'm not going probably to discontinue NSAIDs if I'm still not having satisfactory analgesia. I'm going to add another mechanism of action on top of the NSAID. As we go to the analgesic algorithm, we talk about mild to moderate pain, which is really the only kind you probably should be treating anyway. Acetaminophen is going to be the popular choice, up to 1,000 milligrams at a time, at least for adults. You can then go to NSAIDs, although those two boxes are interchangeable. Do you want to add codeine? Well, I kind of wouldn't. Some patients simply expect it, and I understand that. If I'm going to add an opioid, right now I tend to add more oxycodone. Again, I tend to do that because it's not a prodrug. It works by itself. I can control a little bit better. Have I been successful in this box would also have morphine in it. Have I been successful in asking patients? Well, I've been successful in asking patients to take it. They just haven't said yes. So hopefully in the future, I'll be able to get a little bit more experience with morphine sulfate as a tablet. And well, I would add that into the analgesic algorithm. Excuse me. There may be situations where you need all three mechanisms: NSAIDs, acetaminophen, opioids, all on board, all not at the same time exactly, but all concurrent with one another with some overlap. If codeine is the way you want to go, for whatever reason you choose codeine, you can actually get codeine as a separate syrup or tablet as well. The issue with complicating things with 3 different pills is that you're going to decrease your compliance. As soon as you do that, you'll find that unfortunately your pain control goes kind of out the window, because the instructions to take all these medications are just too complicated to follow. It's been noted that opioids recently, and you can see this article from the New York Times, comes from September 4th, it's not only opioids that we have to worry about. One of the issues is that people aren't taking all the pills that we're giving them, so then they start to self-diagnose. So this article talks about opioids and NSAIDs and acetaminophen. It talks about the fact that you have adverse effects that are sometimes dangerous with NSAIDs. It talks about that you have adverse effects that are sometimes dangerous with acetaminophen. I talked about earlier about acetaminophen being the cause of acute hepatic failure in North America, the leading cause of hepatic failure in North America. So please be careful. This is especially true when we start to talk about the elderly. It's clear that our population is getting older. As our population continues to get older, it's going to create some unique issues that we aren't necessarily ready to handle exactly. When it comes to specific considerations for the elderly, I'll keep this brief. Acetaminophen is probably your analgesic of choice. It's your analgesic of choice because you're not going to have the gastric irritation or the bleeding effects that otherwise could happen. We have to be aware, however, that the older liver tends to not be a liver that is as effective in dealing with the metabolization of acetaminophen. So the possibility of significant liver damage is a little bit higher in the older people than it is in the younger ones. With regards to NSAIDs or their use in the elderly population, we have to be aware of bleeding. Okay, there are toxicities in the GI tract. There are toxicities to the kidney. There are toxicities to the liver that are not exactly the same as they are with acetaminophen, but they are certainly there. It also decreases the effectiveness of all sorts of antihypertensive drugs, the diuretics, the beta blockers, and the ACE inhibitors. That's what ACEI is, the angiotensin converting enzyme inhibitors. You can consider celecoxib, Celebrex. Again, as I mentioned earlier, it's not great against dental pain, but if you really want to go to an NSAID and you're worried about bleeding, you can think about doing that. Generally speaking, I will still use my ibuprofen, 200 milligrams, 400 milligrams, and I tend to get good results with that. I haven't, generally speaking, had to go into Celebrex, but I'm willing to do so if the indication arises. With regards to the elderly and opioids, we have to be really aware of its sedative effects. It's bad enough when anyone falls. It's really bad when someone who's elderly falls who isn't used to falling anymore, because their damage is usually quite significant. If they break a hip, the reason that people die after they break a hip isn't so much because of the broken hip. It's because either it throws some sort of blood clot somewhere as it's healing, or the fact that they are immobilized now, they catch pneumonia and they die. So we want to be very careful with regards to anything that can affect their coordination that will give them sedation. The effects of opioids are going to be increased in the elderly population. They're going to be prolonged in the elderly population because their metabolic processes simply aren't working as efficiently as otherwise they could. We have an increased likelihood of adverse reactions. Their constipation is going to be worse. Their sedation is going to be worse. Their respiratory depression can be worse. So generally speaking, I try to avoid the use of opioids in the elderly population. Getting towards the end now, and we're going to talk a little bit about some drug interactions. We really, in my opinion, don't have a reason not to know about a drug interaction. The internet has all of the accumulated knowledge of all humankind for all time. Given that everybody, essentially, in North America has probably even a smartphone or at least a computer at their beck and call, conveniently at their beck and call, there's really no excuse to not be aware of drug interactions. I've listed a couple of websites here that have all kinds of drug interactions included in them. All you have to do is type in whatever drug you don't know, and it will tell you what the drug is, how it works, and other drugs to be aware of. Medscape.com, WebMD.com, drugs.com, all very good websites. They also even have pill identifiers, and so sometimes the people are stuck for what is this medication? Here's the pill, I don't remember what it's called. If you can even manage to get a photo of it and upload it to one of these sites, the site can actually identify what the drug is. After you know what the drug is, you can find out what the proper dosage is, what the interactions are, what the precautions are, what you need to warn your patients about. Again, Dr. Google is a really good doctor, and we should be willing to use it a little bit more often perhaps than we have been in the past, because the internet contains all of the accumulated knowledge of all humankind for all time. Folks, I think I've gone through the things that I wanted to, and I have left a little bit of time to discuss whatever issues may have come up. So I thank you very much for your time. Thank you for your attention. I hope I haven't taken you away from anything particularly important as the new TV season gets started. And I'm willing to sit like this guy as a target and take questions from the audience.
Dr. Nkansa, we're getting a couple of questions here in the box.
Okay.
So I don't know if you're able to maximize the box. I'll read off the first one. What do you think about transdermal diclofenac in postoperative pain management?
Transdermal diclofenac. Sorry, I don't see the question here, but okay. Let me play with my screens.
Sure.
I don't have a big issue, I don't think, with that. In the context of dentistry, I wonder what they would be trying to treat. Do I think, for instance, that tooth pain can be handled transdermally? I don't think it's I don't think it's any better of an option than orally. Again, if the only reason that you're doing that is in order to avoid the GI irritation, I understand that. I'm not sure how to titrate the dose very well. One of the issues with putting topical creams on is you're not actually sure how fast or how well the drug gets into the system. So philosophically, I don't have an issue with it. Would I choose to use it? Probably not, I don't think. I have another question that's popping up here. So the question is with regards to Celebrex and why we can't use it in patients who have peptic ulcers. Celebrex is a COX-2 inhibitor, but it's not as pure as we would like it to be. Very few drugs are absolutely pure. We want the beta-2 agonist, for instance, salbutamol in an asthma attack, except it really isn't only beta-2. It's primarily beta-2. Celebrex is COX-2 weighted, but not COX-2 only. So we are still going to get some of that, the prostaglandins that are going to affect the GI tract. You still can get a little bit of gastric bleeding, gastric irritation. It's going to be certainly less, but if you're in a situation where you have an active peptic ulcer, you really don't want anything that's going to irritate the stomach any more than you have to. And NSAIDs are always going to be a worse option than something like acetaminophen. Just reading through another question here. What is the therapeutic dose of ibuprofen and the ceiling dose? And why would you give more than the ceiling dose of a drug? The ceiling dose is a daily with regards to ibuprofen, is a daily maximum. The daily maximum is 3,200 milligrams a day. Why would you give more than that? Well, you probably shouldn't. The question is the ceiling, or should the ceiling be lowered? Some people are certainly talking about risks with regards to stroke and MIs being induced at doses greater than 2,400 milligrams a day. That is less than the ceiling dose in the first place. So if we put this into context, let's just say you're one of those practitioners who likes to give 600 milligrams of ibuprofen at a time. That's the prescription strength, at least in Canada. In Ontario, the prescription strength of ibuprofen is 600 milligrams. So now you're going to ask your patient to take 600 milligrams every 4 hours, which is a reasonable thing to do because the instructions say that you can take this every 4 to 6 hours as needed for pain. In 4 doses, you're going to be above 2,400, or you're going to be at 2,400 milligrams. In 5 doses, which is a possibility, you're going to be at 3,000 milligrams. If that's the case, you're not at a ceiling dose, but you're higher than, certainly than the therapeutic dose, and you're not exceeding the ceiling dose. Having said that, if the ceiling dose were lowered, and it would be a little bit arbitrary to lower it down to 2,400 milligrams, then your 5 doses of 600 milligram tablets would actually take you over the ceiling dose. So it's a little bit of a complicated question, especially with regards to ibuprofen, because they're playing with what the ceiling dose would be anyway. Currently, the ceiling dose in Canada is 3,200 milligrams a day. That's actually very hard to exceed. If they were to drop that to 2,400 milligrams per day, that wouldn't be all that hard to exceed, but you would have a reason to do it, because you can give ibuprofen at 600 milligrams a time, and you can give it every 4 hours. Here's another question. For patients with hepatitis C who do not have cirrhosis, can you still give acetaminophen? So anyone who has any level of hepatitis is going to have some level of inflammation in their liver. Anytime you give acetaminophen, you're going to tweak, at least a little bit, the inflammation in their liver. Is it bad enough that you have, cirrhosis is a fairly down the road form of inflammation. It's a long-standing inflammation, and it's damaged the liver to the point where even the liver can't repair itself, which actually as an organ it's very good at doing. But if a patient or a liver is cirrhotic, it's now maxed out its own ability to repair itself. If that happens, you need to be very, very careful about how you're going to use something that you know is hepatotoxic. That would be acetaminophen. Can you still give it? I suppose you could. My question then would become, why are you looking to avoid, my question internally would become, why are you looking to avoid NSAIDs? If you're doing so because you're worried about the GI and the person has a bad liver, then you're kind of stuck. Now, I totally acknowledge this kind of situation happens because people tend not to be sick with one system at a time. They tend to be multi-system failures. If you're having a multi-system illness and you have to make your difficult decision, then you need to sit down. You need to figure out maybe a short term is going to be okay. And again, this is where we talk about a maximum dosage being for maybe 5 days. But maybe you also go back and forth. Maybe if you go back and forth between the NSAID and the acetaminophen, you get to lower the dose of both, but you're still handling the pain. I hope that answered that question okay. Looking at another question about Vicoprofen. Sometimes, oftentimes actually, I can't really answer a question from the standpoint of here's my experience with it because I may not have experience with it. Vicoprofen is an example where I don't have any experience with it. So I appreciate that question. I would love it, Dale and Jen, if you would be good enough to put that onto the list of questions that we'll get that I can look through afterwards, and I'll think about how it compares to acetaminophen and opioids. Generally speaking, what we're talking about with regards to acetaminophen and opioids is what they'll call the wisdom tooth model, and they'll sort of take out wisdom tooth from one side of the mouth, and they'll give this analgesic, and then they'll take out wisdom teeth from the other side of the mouth, and they'll give this other analgesic, and they find that the combination of acetaminophen and opioids are pretty good. That ends up being a bit of a standard bearer, and that's okay. I don't have an issue with that. In terms of how Vicoprofen would do in relative to that, I don't know. I haven't tried it. I will be happy to have a look at the literature that's surrounding that, and I will give a much better answer than the one I just gave if I get a chance to do a little bit of homework on that. I have another question with regards to tramadol and where does it fit? Again, unfortunately, my answer is going to be kind of similar in that I've never used tramadol because I've never actually had to use tramadol. Tramadol is a narcotic-like pain reliever. It's with regards to its ability to be addicted. I think that could happen. I think the extended release formulations are probably fine. It acts more or less like a narcotic medication. It seems to have its own ceiling. I can't tell you that people aren't going to be hooked on it and abuse it. It is a possibility. I haven't needed to use it, to be quite honest with you. I feel that it's an opioid without being an opioid. And my personal discomfort with that is that I'm not really sure how it works or where the effectiveness is. I can make opioids and NSAIDs do some pretty cool tricks, I think, but it's because I sort of understand how they work. When I begin not to understand how a drug works, I begin to lose comfort and I begin to lose sleep over that. So again, this is something I'm happy to look into, and I'll talk about where tramadol fits with regards to the other medications that I mentioned, but I'm going to have to do a little bit of research on it and sort of think about where that is because clinically I really don't have any experience with it. Just reading through another question here. For patients with confirmed allergy to ibuprofen and naproxen, ketorolac, so we're knocking off all the NSAIDs, and has side effects to acetaminophen, what's your next line of anti-inflammatory? Well, you're stuck for anti-inflammatories and analgesics. So for the best anti-inflammatory is going to be a corticosteroid. So if I'm worried about that sort of thing, and I know that I'm doing something that's going to induce some inflammation, one of the strategies that you might actually employ is injecting some dexamethasone right at the site of action, the site of trauma. So there are a couple of papers out there, and I didn't talk about this in the talk, but it's actually a very good question. One of the things that you can do is use a corticosteroid injected peripherally. You could even use it as a pill afterwards, peripherally, to decrease the amount of inflammation. So when it comes to anti-inflammatory action, yes, NSAIDs are good because they're analgesic as well, but if all you're looking for is the anti-inflammatory effect, corticosteroids are far superior. The downside to corticosteroids is that they're fairly slow in their onset. Having said that, when you inject it directly into the area of trauma or into your site of operation, it's very likely to do very good things for you. I've only read a couple of, there aren't that many papers on it, and I've read a couple of them, and they're all giving pretty good results to actually injecting dexamethasone at the traumatic site. So that's what I would do with regards to the anti-inflammatory. With regards to the analgesic side of things, if you're stuck because you can't use essentially any NSAID and you can't use acetaminophen because of its adverse effects, side effects, then maybe you're looking at your morphine sulfate tablets. Maybe you finally have the patient who's going to say yes to that particular idea. That, I think, is where I would go. I would look to reduce the inflammation using corticosteroids, which you can first inject locally and later on you can take as pills, either dexamethasone or prednisone. And then for the analgesic, at least in the short term, I might look towards an opioid, understanding all that comes along with the opioids. And I wouldn't go with codeine because I don't think that's good by itself, because as a prodrug it doesn't work very well, but a morphine sulfate tablet or tablets would actually work, I think, fairly well. Looking through another question, and the med consult is fine, but frankly, I don't know what the physician is going to tell you. Because if the patient is going to have bad reactions to NSAIDs and is going to have bad reactions to acetaminophen, then the doc is just going to come back and tell you that they're going to have bad reactions to NSAIDs and acetaminophen. I have no issue with maybe they're finding a different way around, but please understand that physicians don't have a good idea for what dentists do, just like dentists don't have a good idea for what all physicians do. So they're not very good at handling dental pain. So another question here, are there any concerns with NSAIDs and hepatitis? In the long term, the answer is yes. In the short term, the answer is no. In the short term, the main organ that I'm worried about with regards to NSAIDs is going to be the kidney, or are the kidneys, assuming you have two of them. The renotoxicity is far more significant than the hepatotoxicity. It is possible with larger doses for a longer period of time to have some adverse effects in the liver, but generally speaking, I'm not worried about NSAIDs with hepatitis. Again, I'm not looking to put people on long-term chronic therapies with any sort of analgesic. I'm looking to get them through the time where natural healing kicks in. Maximally, in my head, I'm thinking about 5 days. These are great questions. Well, with a little pause in the action, one of the things I probably can mention is that I think, if I'm not mistaken, the AGD is going to make available a handout that everyone who has signed into the webinar will be able to access. We're also going to hopefully compile some of the questions that I may not get a chance to answer, and so I'll be able to answer those in written form, and we'll be able to distribute those hopefully in a PDF form or something like that. I have another question that asks, do I prescribe ketorolac, and if I do, under which condition? I really don't have a specific path to take me towards a specific drug. Everybody has a first choice, and my first choice is always going to be ibuprofen when it comes to an NSAID. Do I have an issue in prescribing ketorolac? No. When would I do it? I would do it when I think the pain is going to be significant. I would do it when I think that, primarily I would do it when I already have an IV started or something like that. Now again, being a dental anesthesiologist, a lot of my patients, about half of my patient population, has some level of sedation for their dental work. When that happens, I already have access to their circulation. I can give ketorolac either intramuscularly or intravenously. Because I can do that and because I have an IV running, I might just choose to do that. Even if I have an IV running and I only want to give an intramuscular injection, I'll do that. Here's a word about the intramuscular injection. When you're going to ahead and, if you will, bunching up the muscle before you give the intramuscular injection, you actually probably don't want to do that. Use your fingers to kind of spread down the muscle as opposed to bunch it up. When you bunch it up, your chance of giving it effectively a subcutaneous injection is a little bit higher. So one of the things you might want to do is just sort of bunch or stretch the muscle down and then go ahead and use your 1.25 to 1.5 inch needle to get it right into the muscle. You want to get deep into the muscle. With ketorolac, you want to follow that up with 10 or 15 milligrams by mouth afterwards. It's a very effective routine. Generally speaking, I don't have to use it, but it's one of the places that I would go if I found I had a failure in managing the pain with just ibuprofen? Terrific question. Thanks.
Thank you, Dr. Nkansa. And as you mentioned, we will make a copy of the questions and answers available as a handout for this webinar. Ladies and gentlemen, sorry, go ahead.
No, I just said that's perfect. That's great. I look forward to seeing any other questions that might come in.
Great. Thank you. Thank you very much, Dr. Nkansa. Ladies and gentlemen, that concludes our pharmacology webinar, Analgesics in Dentistry and Their Effective Use. We'd like to thank you for joining us this evening and remind you to please take a moment to complete the evaluation that will be sent to you via email within the next 2 to 3 business days. Please visit the AGD Online Learning Center at www.agd.org/OLC to register for any of our upcoming webinars or to take advantage of the 6 free on-demand webinars available to all of our AGD members, or to access the recorded version of this webinar via your personal online learning profile. Our next and final webinar in the AGD Pharmacology series, Addressing Polypharmacy for Medically Complex Dental Patients with Dr. Larry Williams, will be on October 12th. Thank you again for joining us this evening. You may now close your browser to disconnect from this webinar.